Let's see. Hopefully people can join us. Great. I think we will have a couple of more trying to join us, but I'll keep an eye on that. And we are going for British punctuality, so we are already 2 minutes late, guys. So we're gonna get started with another webinar. So thank you guys one more time for joining us. Now, for some of you, it might be the first time that you guys are here. For others, you might have seen something like this before because we usually run a lot of webinars with Ohana Animal Charity, and we are starting to do a couple more as well, which just means that we have more content available for vets from all over the world. For those of you who are here for the first time, just so you know, my name is Andrea. I am the founder of UniVets Global, which is a company that is today here bringing you this content. And we are basically a training company for vets who are dedicated to saving animals. And we do this by helping you guys with your confidence level, with your skills level, and making sure that you guys can become more skilled so you can save more animals. That's pretty much what we do. And what we do is we basically specialize in hands-on skills, hands-on practical skills. Oops, sorry, lots of things happening on my screen. And to give you an idea of what we do is we follow a method that we have developed to make sure that when you are with us to learn something, you actually do learn it. So we basically follow a few steps, and I'm not going to cover all of these, but for you guys to have a bit of an idea about what we do, we are the most practical training provider that you can find. So you will see that one of our steps, which is step number 2, it's a step where we actually do skill acquisition, where we get you guys to learn the skill, the practical skill. No one in the world, as far as we are aware, offers as much hands-on experience. So we do 5 full days, and we do a few cool other things, so you don't really have to worry about setting up your journey or, you know, organizing your stays and your meals and everything. So we basically cover what you guys need to learn, how to learn it. We teach you this skill. We make sure that you can learn this without a lot of stress around you. And then we make sure that you have follow-up on your skills and you can increase and keep updating those skills as well with a series of case discussions and access to the instructors for your courses. So basically, to give you an idea, we've now had more than 100 vets joining us since we started this journey, and we basically focus on neutering. So we teach different levels of neutering, different types of neutering, and we do both cats and dogs. We do abdominal ultrasound, and we get people to reach a very good level of skills with just 5 days. And then we do echocardiography, where you can see one of my kitty cats semi-sedated, having a heart scan. Oh, it's maybe not a heart scan. I just realized it's one of the abdominal scans. I'm pretty sure he's had a heart scan at some point, though. For those of you who have not really visited our new website, guys, you can go and check it out because the website is now brand new. There is a Portuguese version and an international version in English. We're going to have a nice, cool video showing up our academies and what they look like. We are currently organizing dates for 2025, 2026, 2025. I think we only have like 1 or 2 spaces left for echocardiography, and everything else is pretty much fully booked already. But if anyone here is working with vets who need to take the RCVS exam, we are, as far as I'm aware, one of the only providers that actually does training for this as well. And we do this as well with the OSCIs. So website is different, so you may have noticed if you have been using univets.global, we are now www.univetsglobal.com. So we have univetsglobal.com and univetsglobal.pt for the Portuguese website. You can still access univets.global, but you're going to be asked to go to choose, but just so you guys have an idea about the news. For this webinar tonight, as you guys are already familiar with things, you're muted. Only me and Ângelo are not muted, but I'm gonna shut myself really quickly. The webinar is about 45 minutes long, and then we have space for Q&A. What we're gonna do with the Q&As, I'm gonna ask you guys to use the chat function to post your questions, write them down as you get them on your brain. during the session. And then at the end of the session, we go through all of those questions that you guys have. What we will do is we're going to have a discussion about Leishmania. It's a disease that vets from Portugal, we're very used to looking at this, unfortunately. It is a very common disease in certain areas of the country, but it's not very common in the UK. However, it's becoming more and more common, and not a lot of the cases are simple and straightforward. A lot of drugs are not easily available, so there's a bit of a question of what do I do with this dog that has Leishmania? For those of you who are in the UK and need your CPD, we do provide the CPD QR code, the one CPD QR code for the app for tracking your CPD. If you guys are somewhere else and you'd like a certificate, I will provide at the end of the webinar the email, which is our email, for you guys to request a certificate in writing. Now, I'm going to very soon pass the baton to Ângelo. So Ângelo is our speaker for today. He is a vet originally from Portugal, but he actually has a very international career and has worked in a lot of different countries. He's worked in Portugal, Spain. He's also been working in the UK and in Sweden. He has a postgraduate certificate in small animal internal medicine, and he's also been doing a lot of work with organizing training and CPD and mentoring for vets that he's working with in the large hospitals that he's been working with. I'm sure that this introduction doesn't make a lot of justice to Ângelo, but I am also sure that as the session goes by, you will see that we are in for a treat and a very good webinar. Ângelo, I'm going to stop sharing my screen so you can start sharing your screen and we can get started. And I'm going to mute myself so we don't have issues with me distracting people with the sound of my cats coming over.
Perfect. So, good evening, everyone. Thank you very much, Andrea. It's been it's a joy to join this webinar today, and I hope everyone gets a bit of information about this somewhat challenging disease. Like Andrea was saying, we're quite used to it in Portugal and in Spain, but to be honest, it was always a bit of a struggle in the UK while I was working there. It's getting a lot of cases. It can be a bit challenging trying to define what to do with this condition, trying to get to a diagnosis, and this non-endemic to endemic zones, it can be a bit challenging to make decisions as time goes by. I'll feel free to ask any questions at the end. It'd be great to share the knowledge that we have and trying to help you as much as possible. We'll get into this part of the webinar and hope you guys enjoy. So, as a Leishmaniasis, if you're aware, it's we're going to try to make this more of a practical look. I'm not going to go dwell a lot in all the theoretical aspects, the immuno part of it and how it develops and what a lot of information that can be just found in books. We're trying to look at more at a practical way so you can use in your daily practice as well, which has been the most important part for me mostly. So I'll just yeah, if this is working, yes. So just simply to go through the basics, what we see in terms of Leishmania is caused by this protozoal flagellate, which is Leishmania. Most of cases are from Leishmania infantum, which is what we have in Europe mainly. There's over 20 species of Leishmania that you can see. The most common ones, apart from the infantum, will be Donovani, Major, Tropica, and Mexicana. But we're looking more of the Central South America areas that see a lot of different species of Leishmania. Focusing on the European side of things, what we see most of the cases are Leishmania infantum. It can cause a variety of forms of disease. What we usually tend to see is the cases of visceral leishmaniasis, which is quite common also in South America. We see affecting people, children, and immunocompromised humans. We have the cutaneous leishmaniasis, which is the most common form that we tend to see in our patients. And there are some, of course, some reports of the mucocutaneous leishmaniasis. There's some reports of cases, you can find them online as well, from this form of the disease from Israel, for example. There's some interesting reports of dogs from. It is transmitted by the phlebotomist, although we tell our clients, oh, this is a mosquito thing. It's not a mosquito. And we should not call it. I'm sure there's a lot of researchers that would not appreciate if we call it a mosquito. It is a sandfly. And only about 3% of the sandflies of the phlebotomist actually harbor Leishmania infantum in endemic areas. So although it's a very challenging disease and we see it quite often, only about 3% of these sandflies can actually carry and transmit this condition. So going again very quickly through the basics about the infection, we all find the life cycle of this protozoal flagellate, how it affects dogs and cats and humans, which have the most interest to us in general. We're going to see the difference within the promastigotes and the mastigotes that we see within the sandfly and within our patients. But one thing that is very, very important when we deal with Leishmania is the incubation period, because this can last for a very, very long time. These animals can be infected, they can carry the disease and show signs of the disease within 7 years. And particularly, I've had a couple of cases, and most recently one case in Sweden that the dog traveled, and it was already in Sweden for about 6 years before it actually developed the clinical signs of the disease. So it's very interesting to keep in mind that recent travel might not be recent, as in terms of the importance of this disease. So recent travel is always the kind of question that we ask patients and our clients. But things that can take over 6 years or 7 years are quite important to consider as well. So as we go through this simple image of what we have within the sandfly, we have the promastigotes, and within our patients, the dogs and the cats, we have this particular image of the mastigotes when we try to diagnose them. So there are different stages of this protozoal flagellate, and we see it as they are in an infectious form within the sandfly. They need to transform before they can become infectious to the patients when the sandfly bites and transmits to them the disease. When we talk about geographic distribution, this is always a very interesting part because this is forever changing, and unfortunately, as you know, changes within the travel of our patients, within things regarding climate change. Quite a few years ago, we had no particular concerns about Leishmania in Portugal. This was also a North Africa problem. Now it became our problem, and soon will become a Northern Europe problem as time goes by. Unfortunately, that will be the trend and how we see these things going on. So it is endemic to over 70 countries within the world, and it's present within places as Southern Europe, where, as you can see within this graph, and the presence within the Mediterranean, there's not one particular area that's free of Leishmania. We see it everywhere. And then we have cases within Asia, Africa, South and Central America, and they're quite common as well. Then we have the zones of potential areas. As we see the expected presence of known cases, and the new cases with no history of travel to endemic areas are the concerning part of new ways of transmission from within the disease. And as we look at the progression, and we tend to realize what's happening in specific countries within the geographic distribution. When we specifically talk about clinical signs, as we see our patients, there's a long list of things that we can expect with Leishmaniasis. The dermatological signs are the ones that will catch our eye most of the times. We have the most common things of exfoliative alopecia, periocular alopecia, papillodermatitis, lesions, ulcerative lesions, and the onychographosis, the growth of the nails. That's quite unexpected in patients, and the owners sometimes notice that because the position of the paws, the dog's walking a bit funny sometimes. We do see quite a lot of ocular signs, especially uveitis, corneal opacity, and keratoconjunctivitis is quite common as well. Although others can be present, they might not be as common within these patients, but any of these signs will be very concerning when we have cases of Leishmaniasis, especially epistaxis. We can have unilateral epistaxis. We can have signs of lameness, and that's usually related to polyarthritis, quite a lot of pain in these patients when they're trying to walk, and then changes within signs of vasculitis, myositis, presence of thromboembolism is common, and not as common, but also reported some neurological disorders can be present. Other very unspecific signs, as we all have for our patients, regardless of the disease, we have vomiting, diarrhea, fever. It can be intermittent. We can have signs of PUPD, lethargy. We can have patients that have an increased appetite in the early stages of the disease. They can then progress to decreased appetite and hyperexia and anorexia. But we do tend to see loss of body weight most of the times when we have progression of the disease as well. And although not always, but we can have generalized lymphadenopathy. Now we can ascertain and try to get samples from those. It will be quite interesting to have. Clinical signs, when we look at photos of Leishmania, we're going to think about dogs with a lot of ulcerative lesions that will not heal, especially around the pinna, which is very common to see little areas that keep bleeding and they're not healing as they should. We have these very ulcerative, very horrible lesions with periocular alopecia with ulcerative areas. As you can see, this dog also within the pinna seems like part of it's already missing because of how it affects. Then we have, as we were discussing, the ocular signs, epistaxis, weight loss, the enlarged lymph nodes, and some discharge, ocular or nasal discharge in some cases. And then we can see a lot of these small bits, as you can see in that photo, the onychographosis, the long nails, the ulcerative ocular and mucocutaneous junction, alopecia and ulcerative lesions. And then sometimes we get these extreme cases when we have incredibly severe uveitis that is not controlled, and we get to the point that enucleation has to be done. This is very uncommon. I've only seen a case like this. This is very, very, very severe. But Leishmania could be simple. I've had cases where we can have just a small wound in the foot pad and a little paw that's not healing. Everything else is perfectly normal. They have high titers. And we have a dog with a up to the other extreme where we have dog with severe skin lesions with weight loss and vomiting and diarrhea. So it mimics a lot of things, and we need to be aware of these cases. It can be anything in terms of lesions as they present. Moving over to the diagnosis part of what we're going to investigate, we're going to find, usually when we have these patients coming in, we're going to do some basic workup. We're going to try to get hematology, biochemistry, basics to guide us to our next step. The findings will, the most common findings will be these on the list: the non-regenerative anemias, hyperproteinemia and hypoalbuminemia will be quite common, and of course the hyperglobulinemia, most commonly the polyclonal gammopathy, but it has been reported in some cases monoclonal gammopathies also it can be present. We have in some cases of azotemia, which would be more severe advanced stages of the disease. Proteinuria. As azotemia and proteinuria, we can think about the deposition of immunocomplexes that will lead to glomerulonephritis, vasculitis. Then we have the involvement within the kidney disease and progression of the kidney disease. In cases of thrombocytopenia, that will lead to hemorrhages in some cases. And we can have either leukocytosis or leukopenia. It's quite variable in these patients. When we talk about the next steps in terms of diagnosis, what we're going to do with the information going forward. So we're going to start thinking what tests do we want to take, what to consider about all these little changes. The most common in practice, especially in Portugal, we're gonna do the qualitative serology. Quantitative serology will be usually the next step. We do a quick test, a Leish test that we will do in practice with those very rapid scans to get a positive or negative result. And then we usually take it a step forward to do the quantitative serology. While in the UK, you might not have access to some of these tests, because if they're not as common, practices will not purchase them to have available all the time, because they'll expire, and then it's not a big investment. So it might be that you simply go to the quantitative serology with the immunofluorescence from ELISA test. That's available in many of the labs present there. We'll give you a tighter cut, and we'll give you the reference values as well to let you know if it's a high, low, or the intermediate, depending on the lab as they name it in general. Of course, we can always do a cytology, histopathology, immunohistochemistry. Cytology, as you've seen from those early images, if we look at the presence of Leishmania within the sample, then we get our diagnosis as it is. You can sometimes find it in a simple swab of dog with epistaxis. You can find them there. If we're going to do cytology of lymph nodes, it's quite good as well. The samples, including lymph nodes, spleen, the skin lesions, and bone marrow. Of course, sampling bone marrow is not as straightforward as you can imagine on your 15 minutes consult every day, but something to consider. We used to do that quite a few years ago in Portugal. Now we move to better results, and sometimes quite reliable. One thing to keep in mind is when we're doing a PCR, which is the most sensitive, as we look at these samples, blood and urine are usually not reliable samples. You should not be using these tests, because then you'll have a potentially false negative, and this should not be the kind of thing we should be spending our money on with PCR of blood and urine. Okay. Qualitative serology, quantitative serology will be the first steps if you have a concern about Leishmania with the history from the patient. And then you can, if you're not entirely certain of this, or you have areas that you can sample, then a PCR will give you a good idea as well. But look for the lymph nodes, the spleen, and skin lesions will be the best way to go forward. So as you can see, we're going to find these changes within our cytology, which was quite good. The first one, the one on the top, that was from a little sample from a dog with epistaxis, and we could clearly see them there. And then we have these beautiful images of where you can see all the Leishmania floating around there, and you can have your diagnosis then present. So when we talk, we have all these steps of how we're going to get to a diagnosis and what we're going to do after the diagnosis. Of course, we're going to go through the history of travel. We can consider the presence of other animals within the family that have had history of travel, and consider the likelihood of the disease. We're going to try to test it. If we're going to get a positive result, or a result that will continue with the suspicion as it is, you're going to try to treat it. We have these staging, these stages of the disease that we need to consider so we can define what's best in terms of treatment ongoing. So we can have a just mild disease with a negative to low positive levels, and we do have quite a lot of patients with that, with no clinical signs whatsoever. It's just a routine test. Sometimes we can have them positive. We're going to try to figure out what to do in these cases, what step we're going to take in terms of treatment. I've had quite a few patients like this in Portugal where there was just a slight concern, and we have presence of low, very low positive antibody levels. Then we go for the stage 2 when we have signs of moderate disease with low to high antibody levels, and the most common clinical signs, the dermatological clinical signs would be the most common ones. Then we have the stages 3 and 4 where we have severe and extremely severe disease. We have high antibody levels with clinical signs that result from the immunocomplex formation. When we have we can stage them when it comes to kidney disease, stage 1 or higher, with the UPC being higher as well. And we need to consider always in these cases to follow IRIS guidelines according to how to treat these patients, how to manage these patients when it comes to kidney disease alongside the treatment for Leishmania. And of course, we have the extremely severe disease signs with laboratory lab findings, advanced clinical signs, and we're looking at these 2 stages with guarded to poor or very poor prognosis. So usually stage 1 and stage 2 are good or good to guarded prognosis. Stage 3 and 4 will be a bit more concerned about how the disease is progressing and how much we can control this patient as it looks. When it comes to treatment, unfortunately, the last few years have not brought anything in particular new. We're just playing with the same toys and drugs for the past few years. Nothing has come up recently. Hopefully, there'll be a bit more research when it comes to our treatments we have available. And of course, in UK, we might struggle a lot to get some of the drugs. When we talk about the glucontime, the meglumine antimoniate, or the miltefosine, they can be quite expensive, especially if we're talking about a big dog. And we have to try to get them available. I'm not sure how it is at this moment in time. While I was there, it was a bit of a struggle to order these things and get them available. And of course, more recently, I'm sure it can be a bit of a pain to get these drugs. So we're going to focus on the most common ones we have all the time. We're going to look at allopurinol, which is a leishmanostatic. This will not be a leishmanicidal. This is trying to control the replication of the parasite. Treatment is about 10 mg per kg twice a day. For most of the times, we're talking about 6 months to 2 years, and it will be quite normal to be 6 months. We need to be concerned about transient increase in liver enzymes and the side effect of the presence of xanthine crystals when we treat patients with allopurinol. When we talk about leishmanicidals, we're going to have 2 options mainly. We're going to look at meglumine antimoniate. Usually it's about 4 weeks of treatment. In some cases, it can go up to 6 weeks. Doses will be between 75 to 100 mg per kg. Subcutaneous injections can be once daily, and for a big dog, it'd be a very big amount. So it might be easier to divide the doses. We can usually start at a lower dose, the 75 or even lower, for the first 2 or 3 days to see how they respond initially. And we need to be concerned of pain and inflammation. These are dogs that are going to get injections every day or twice a day. It can be quite painful to inject a large amount of fluid in there. We can have some GI signs. There are some reports of potential nephrotoxicity. We'll go through it a bit ahead after we go through this slide. And then we have the miltefosine. It's the oral preparation. It's around 2 mg per kg that we usually do as a dosage once a day. It's easy to apply. It's for about 28-30 days. Side effects, we can see vomiting and diarrhea, and some patients will not tolerate this as they will start with vomiting quite early on. Sometimes we give it a break and we start after a day or two. So we need to concern if this is an option as well. Okay. So we do have other things that we can try. But when we talk about these, especially immunomodulators, we're talking of trying to stimulate a Th1 cellular response, as we have this working idea that dogs that can mount a Th1 cellular response will be more effective when to control as they control the infection. When we have an immune response, a Th1, Th2 mixed response, these patients will develop clinical signs of disease or more prone to develop clinical signs of the disease. So with that in mind, we have these two options. We have domperidone, which is quite commonly. There's some options in terms of available in the market. We do have the Leishguard, which is the domperidone that's been prepared for dogs. It's a 0.5 mg per kg once a day. It's an oral preparation. It's quite good. It's used for prevention in most cases, twice a year, 3 times a year. It can be used on the mild stages of the disease. Side effects can usually have galactorrhea, we can have vomiting, some polyuria, potential cardiotoxicity is not there's a concern. There's no clear episodes of that, as we use it quite often. And then most recently, there's a paper from 2024 to confirm the use of these dietary nucleotides with HCC, a mycelium extract that's been available for people as well. And this also tends to mount a cellular response and try to improve the immune response from the patient. There are no particular reported side effects. This is a nutraceutical. It's a compound that doesn't seem to have any issues when it comes to side effects. Recent papers showed some good results using this, but these are not leishmanicidals. None of this will kill the leishmania that the patient has. So these are quite good options as a maintenance, as a prevention in most cases, and a help in terms of the treatment. But in advanced stages of disease, we might not be just looking at these options because they will not be as effective. So when we talk about protocols, as we look at the stages and we look at our treatment options, when we have patients in stage 1, it's perfectly acceptable to just go on with a close monitoring of disease progression. Some clinicians will prefer to start allopurinol alone, or allopurinol with a leishmanicidal for a short period of time. Domperidone can be quite effective in the early stages of the disease. This will mean as trying to mount this cellular response, and can be used every 4 months to try to maintain the infection on the low antibody titers. Stage 2 of the disease, we're talking about different type of protocol. We're going to start looking at the combination of allopurinol with meglumine antimoniate, or allopurinol versus nortepezile. And this option can be easy made because this choice between one or the other can be quite simple to say, we can't have one, we only have the other, and that's it. Our choice is made for us. Or when we have the agony of choice, then we're going to look into these 2 options, trying to figure out what is best. And when we look at papers, there's no specific difference between one and the other on the short-term period, but long-term, there was a long-term study of how these 2 affect. It seems that meglumine antimoniate or glucantime, the injections, will have a better outcome long-term with less clinical relapse and a better outcome in general. So that it will be to consider, seems to be more effective as a leishmanicidal long-term compared to nortepezile. Stage 3, we're going to look at the treatment exactly as stage 2, allopurinol and one of these two, and then we're going to have to follow IRIS guidelines, most of these regarding azotemia. We need to consider all the guidelines when we talk about IRIS staging 1 and 2. And between meglumine antimoniate or miltefosine, there are some papers that show, although patients with that were treated with meglumine antimoniate, the injections, did not develop azotemia, it seemed like as we look at histopathology from the kidneys of these patients treated with MGA would had signs of tubular necrosis, showed early signs of nephrotoxicity. So we need to consider that in some of these cases. Although being more effective, some clinicians still go for the glucantime than the treatment compared to miltefosine, but there are some studies that show us some potential concerns in the future with nephrotoxicity. When we talk about stage 4, we're going to look at allopurinol and the ancillary treatment with supportive IRIS guidelines as it is. We're going to look at severe disease, advanced disease, and we need to be concerned of how these are going to affect our long-term outcome. The prognosis is as guarded as it is. Some clinicians will still use the leishmanicidals in these cases, but there is no specific reported success for leishmanicidals at this stage. So it is an option to use, but we don't have enough data to say this is helpful in a way. We're going to try to support in the kidneys the presence of these vasculitis, glomerulonephritis, that advanced kidney disease that we need to support looking at our IRIS guidelines. So another important thing as we diagnose, as we treat, and we're trying to monitor what to do next, there's always this bit of a question: how often am I going to do this? How soon am I going to check these patients? What I'm going to do after the treatment? Fine, I'll do it for a month. I'll keep them on allopurinol, and then what? What to expect from all this? And these questions are quite the kind of thing I had quite often in the UK. And there's always a bit of a should I not? How soon to see it? The patients and the clients will be a bit annoyed about how often you can come back to them. So as monitoring, I think doing a bit of a sum up of what we have after diagnosis within the first year, we're going to do the first check after 15 days. Especially if you're treating a patient with a leishmanicidal, with the injections or the miltefosine. We're going to try to assess the drug side effects. We're going to see if they can have transient increase of liver enzymes, renal parameters. If they're already elevated, we're going to monitor how these drugs are affecting the kidneys as well and what they have. We're going to have them back 30 days for a little medical follow-up. We're going to check their weights. We're going to look at the lymph nodes. We're going to see how the wounds are healing, if the skin's a little bit better, if they're eating quite well, if they're vomiting, diarrhea, all these things. And then every 3 to 4 months, we're going to recheck some bits. We're going to look at CBC, biochemistry, urine analysis, UPC, and if possible, it's not possible in a lot of places, we're going to look at protein electrophoresis, and that's looking, instead of checking the antibody titers again, protein electrophoresis will give you a better idea of how the disease is progressing, if it's improving, if it's not improving. Antibody titers would not give you lots more of outcome if you do it less than every 6 months. So there's no point of checking every 6 months, or better, checking sooner than 6 months for your antibody titers if they were elevated in the first place. Then we're going to take the next step of the second year and third. So we're going to do checks 4 to 6 months as it's okay. We're going to 6 months after the diagnosis, we can, as I mentioned, repeat the serology for the antibody titer, see where this is taking you. Of course, we can always do some real-time PCR can be performed to do this parasitic load quantification with a narrow lymph node. It's not that common to be done. It is academic in some cases, but we can give you parasitic load with the information you get. And then what I usually tend to do would be every 3 months, usually around the 3 months, ask the clients to bring in urine samples, especially if they've been on the allopurinol. We're going to check the crystals. In some cases, we'll have patients come in with a little urine sample, and it looks they've just picked it up from the beach. It's just crystals everywhere. It's just floating with sand in there. So it can be quite bad with that. So we need to get along with the prevention of these cases. And when we talk about allopurinol and how to control the xanthine crystals, we're going to look at low purine diets. If allopurinol is even with the low purine diets, and we have some options, some commercial diets or even some home cooked diets, trying to control. We do have the option of eventually swapping the allopurinol for something else like the Improvmune that will have a good result long term as a maintenance thing if the allopurinol is just creating too many crystals for these patients. Of course, we don't want them to get blocked and then have a worst outcome of all this. When it comes to preventions, we look at a combination of products. Of course, if you're not on endemic area, the concern will be slightly different. When we live with Leishmania every day as we walk out the door, we're going to look at repellents, the spot-ons, the collars, and then we're going to combine that with the vaccines, the vaccinations. So the cannulation, which is the Verbac one, has been around. It was the first one developed. There's a few different ones within South America, but in Europe we have basically these options at this time. Cannulation seems to have a lower efficacy compared to the newer Letifen, but they are around the 72% efficacy range. The advantage compared to one and the other is the one vaccine, one jab compared to 2 or 3 boosters, and then an annual vaccination. So cannulation seems to be slightly different compared to the Letifen. Letifen is just a one-time jab and will give you the year. Of course, for these patients, as we're talking about, I'm not sure patients is actually quite fine. There's no concerns about Leishmania, and we're going to get him somewhere. We should always, especially in these areas, we test before we vaccinate. If they are positive, there's no point in vaccinating these patients. They will have no outcome within the prognosis of the treatment. Other therapeutical options, we have a couple of things. There's nothing particularly very advanced at this time. There is a paper that will create a bit of a discussion when we talk about fluoroquinolones in dogs with Leishmania, but this paper has shown that treatment of dog with canine Leishmaniasis with margofloxacin was effective, but of course, using fluoroquinolones in patients with other options available, we need to consider about our antibody resistant patterns, and this would not be a specific first choice. This patient in particular, as they treated patients with margofloxacin, was due to severe and advanced kidney disease, and the options were limited. And then we have this, the potential, this paper of artemisinin, the artesunate, which seems to be a possible something in the future to the treatment of Leishmaniasis, as they are the nucleotides, as we were discussing earlier. And this could be something in the future that will give us another option in terms of nutraceutical supplements that we can use for these patients. One thing that some people will ask about, can I use steroids? Should I use steroids? And how these patients are going to respond to the use of cortisone. There isn't enough evidence clearly against for the use of steroids. We do need to consider as an individual, per individual case, the quality of life of the patients, the presence of glomerulonephritis, polyarthritis that might benefit for a short bit of time of an anti-inflammatory effect of cortisone. Has been reported through colleagues from the University of Barcelona. Javier Roda has mentioned a few times in these cases, and Luis Feo as well. They've published they discuss in webinars as well, what to expect in these cases. But usually it's about should we, should not. It might be used, and we use doses within 0.5 mg per kg, maximum 1 mg per kg as a short term to try to improve the quality of life of these patients if we have to, especially in cases of polyarthritis or the ongoing development of glomerulonephritis. When we talk of transmission, on the beginning of this webinar, as we look at how these things are transmitted, we talk always about the sandfly, but there are some anecdotal reports of ticks, of fleas, and of course, vertical transmission and horizontal transmission. We talk about this paper back in 2016, the first report of transmission in Germany of a dog with canine leishmaniasis from a naturally infected dog, so blood to blood. And of course, I'm sure there's quite a few of you have been aware, if you've worked in the UK for a bit long now. There was this reported case within the RBC, if I'm not mistaken, of a dog that never travelled, that got contaminated and he was positive for Leishmania, and he had the other dog in the household that was imported from Spain. Although the sandfly is not available in the UK, he got infected within the transmission from blood from the other dog that was imported before. For the future, we always trying to look at what to expect and what things are going to bring us a bit more. We need to consider the fact that there's some recent papers that have been showing the resistance pattern of miltefosine and amphotericin B, which is another option to treat Leishmania, which is not as common, with quite a bit more concerning side effects, and an older option. But we're seeing the resistance of these drugs to our patients, and of course the allopurinol as well, how much we need to adjust over time, and the meglumine antimoniate resistance to Leishmania within the macrophages. So unresponsive dogs with the treatments that we have available, and as you can understand, there's not a lot of treatments available at this time. There's nothing particularly new coming out. We'll hopefully get something better. We do have these immune modulators, and we try to go through the prevention and try to get dogs with only on the stage 1 and stage 2 of the disease, so we can help them as best as possible. One thing in terms of information, it's always good to give you the information of going and have a look at leishvets.org, the website. You have all the canine and feline leishmaniasis there. We're not talking about feline leishmaniasis, but there's been more increasing reports of cats with leishmaniasis and cats with just signs of chronic diarrhea that were positive to Leishmania, especially within the Catalonia area. That's we've seen quite a few cases. Cats don't tend to have, at least that we've seen so far, all the spectrum of dermatological signs that we see with dogs. But we've had, there's been quite a few reports of cats with leishmaniasis that we're going to find, and the treatment is not that different when we discuss dogs as well. Okay, so go back to this one. I think, I'm not sure if I'm okay for time, Andrea, if it's quite okay.
No, yes, you are. Absolutely fine.
Yes. And feel free to ask any questions.
All right, so yeah, we do have a couple of questions. So I don't know if anyone wants to, I'm actually going to do it. I'm going to put the link directly on the chat because the other thing I'm going to do right now, I'm going to overtake the screen, and I'm going to actually share the QR codes for UK Vets. So guys, who are in the UK, you guys can see this. And now I'm going to open the chat. So actually see the questions that we have. I'd like to be able to make this better looking for you guys, but unfortunately, I think I'm going to be stuck here. So let me get this smaller so I can, because I feel like you guys can see this. I can't make it smaller. Oh well. So there's a QR code for those of you who use the One CPD app for tracking your CPD in the UK. For everyone else, there's information about the next webinars as well. So we're gonna have one with Ohana Animal Charity. As you guys have seen, many of you, we have topic and the date to be confirmed. And then in October, we have another organized on the neurological examination. So it's about being able to perform a good neurological examination, which you guys, because you're here, you will receive information on how to register for that one. It is optional unless you've signed up for all webinars. You won't automatically receive it because we don't want people to be overwhelmed with emails that they don't need. So you can find these on the website within the next week. And if you guys are interested in anything practical, there's more information on the website as well. For those of you who want a certificate of attendance and you are not using the One CPD app, you can email univetsglobal and you ask for your certificate of participation. Now, we do have a couple of questions. I actually did a couple as well because I am working in Portugal and I have started to see some cases of Leishmania here where we before weren't seeing cases. And I have definitely noticed a pattern with a lot of the cases that we see. They present with skin lesions. Do you normally see pruritus with these skin lesions as well?
It's not as common for them to present with pruritus as the first part of it. Of course, pruritus will be present when we have dry seborrhea, when we have lesions that keep not healing, and dogs will be annoyed by it, but will not be the concern of saying a dog with pruritus with these skin lesions will take us to Leishmania straight away. We will, especially like you said, if you're working in Portugal, there's always on the back of our mind, let's test it and just make sure it's negative, and then we'll move forward. But would not be the concerning parts. But of course, dry skin will always be a bit itchy when we see some of these patients.
Yeah, so I was just checking that has been my experience so far. They are not pruritic. Sometimes they look really horribly alopecia, but they are not pruritic, or they're not as pruritic as you thought they should be if there was an innate skin disease. So that's the reason why I was wondering. The other question I oftentimes have is, we always say that Leishmania is zoonotic, but I have never heard of any reported cases in humans in Portugal.
No, there was some reports as I looked through medical records. There were an area in Portugal in the Alentejo. There was some reports, but when we talk about it would not be considered an outbreak or anything, but it will be a concern of patients with AIDS and immune compromised a compromised immune system, young children, elderly people that will have be a bit more susceptible of an infection if they are there. But we don't seem to have enough evidence to say a dog would transmit it. It's more of a dog can be a harbor of Leishmania. The sandfly will then bite the dog and transmit it to someone else, and will be transmitted to a human. But it's not as common. And of course, when we have all these patients in Portugal, like you said, you're going to start seeing a lot of them, and we see patients that have been perfectly fine, and they come in with an epistaxis thrombocytopenia. We're going to find Leishmania, but everyone in the house is fine. Everyone within the family is fine. Everyone within the area is perfectly fine. But of course, with every zoonotic infection, even we talk about leptospirosis and things, susceptible people with immune compromised immune system, it's a bit of a concern. Of course, we need to be extra careful with that.
Yeah. So yeah, that's what I tend to say as well, because we always discuss, oh, it's zoonotic and it's dangerous to have it and so on. But then I remember at the time when I was studying, so that was like many years ago, it was big news that there was a horse with Leishmania, that one of our teachers detected a horse with Leishmania, because before it was only dogs and sometimes cats. I do wonder if cats are very underdiagnosed, but that's a different discussion for another webinar. We have a couple more questions. Yeah.
When we talk, sorry, Andrea, just before,
Yeah.
because that's a question that will, it also appeared to me within the cases that were referred to me in the UK with Leishmania will be some of the first opinion clinicians that were not used to deal with this and saying, well, you probably need to get rid of the dog. This is a big concern, and it can have these zoonotic potential, and this will be a question people will be very worried if, oh, I have a young baby, or I have someone in the family that, will it pass anything to us? So we need to be aware that there is, all we can ever say, there is the potential is there, but it's not that common for the dog to transmit Leishmania itself. Okay.
Yeah. Okay, now comes the clinical questions, the ones that we were going to have. If you have a clinically sound patient and there's normal urine, biochemistry, hematology, but they have a low to medium titer, would you keep them on any medication? What medication? When would you stop? When would you start? How would you work on this case?
It's a very good question. So, as we discuss a stage 1 of the disease, it's perfectly fine to monitor the progression. You don't have to start medication particularly. Over the past few years, we were just thinking, oh, it's Leishmania, allopurinol, do it 6 months to a year, and then we're going to check how it is. But we have changed things, and because we look at the resistance pattern for these drugs that we have available, there are some clinicians that started doing more of a change. So we treat with the allopurinol when we have the signs for it, and see how, even if the titers are low or medium, we're going to treat. If the clinical signs are better, then we're going to stop. And then after that, we're going to check again and see how it progresses. So if we're talking about completely healthy patients, that it's in the UK, not an endemic area, it's been perfectly fine, no clinical signs, low to medium titer, then it's perfectly okay just to use prevention, to use Leishguard, to use it twice a year, 3 times, or every 4 months, or the nucleotides, which seem to have a good response in these early stages, or simply just monitor the progression and see how the clinical signs are going to change. So that doesn't mean these patients are going to develop quite severe clinical signs, but we need to be aware that any action of stress in this body can trigger a replication of Leishmania and develop of clinical signs of the disease. So this is perfectly fine. When to stop and when to restart has to do with the clinical signs. If there's no other concerns, we're going to stop when the skin is better, is perfectly okay, the dog is eating well, has good body condition score, and no other signs, we're going to stop. And then we're going to restart when they start coming back. We can always do the 3 or 4 to 6 months check if everything's fine, sooner if the others are concerned, of course. And we're going to restart if we have enough evidence that the clinical signs are connected to the Leishmania.
Yeah, cool. I think you answered the next question as well, because it was about whether we would use an immunomodulator drug to prevent clinical relapse, which the answer is yes, we can do that.
Exactly. As a maintenance treatment, will be perfectly fine to use those ones.
Yeah, exactly. Cool. I think we'll have 1 or 2 more questions. A tricky question. If you have a dog that is being treated for Leishmania, but it is painful for some reason, is it okay to get a non-steroidal, for instance, alongside the treatment?
Yes, that's a very good question. When we discuss the drugs, saying is it okay to use with the other drugs we're going to use, it is perfectly okay. But we need to consider the potential of nephrotoxicity, glomerulonephritis, and then we're going to add the putting a lot more pressure on the kidneys with a non-steroidal. So we need to consider what stage we have within the kidney disease. If it's a mild case and we're just using allopurinol, will be most of the times okay to use a non-steroidal. But if we can avoid non-steroidals because of the potential risk of the disease itself, then I would go for something else like gabapentin, paracetamol, other options that will be less damaging to the kidneys or less risky to the kidneys itself. Because most of these cases we might not notice if we're not going to do UPCs and kidney samples. We're not going to find some stages of glomerulonephritis. We're going to look at proteinuria. If we have those signs, then we're going to back away from non-steroidals. That's as we look at IRIS guidelines, we're going to remove anything that will damage the kidneys further, as it mentions there. So we're going to focus on following that. If we can control it, the pain with another medication, then that'll be great. If the dog is perfectly fine, there's been no other concerns with regards to renal disease and proteinuria, then it's perfectly fine to use it for a short term. Long term, we need to be slightly concerned. But if it is a patient that's been perfectly fine, use it for a bit longer. That will not be a massive concern because your patient is fine. He has the disease itself, and we're not going to have specific clinical signs of things.
All right, cool. We have another just new question
Yeah.
on the Letifen vaccine. This is from a student, vet student from Spain, and apparently one of the highest prevalence areas in Europe. And Laura was advised to vaccinate her dog against Leishmania with Letifen, and she's asking, what's your opinion on it?
Yes. So looking at all the reports, we see that Letifen has a higher efficacy compared to the other ones. So between one or the other, I would probably prefer Letifen. I'm not working, full disclosure, I'm not working for any of the labs. I'm not being supported from any of the labs, but as I usually use it quite daily within the practice. But always before vaccinating, as if it is the first vaccine, always test. But if you can do as much as you can do to prevent the condition, but just be aware you can use collars, the spot-ons, the vaccination, and the dog can still have leishmania. So we're not never 100% with this. But when it comes to endemic areas, if there's a concern, the upside of vaccinating, it can be, although the dog can still get the disease, you can reduce considerably the clinical signs that you can develop. So when it comes to vaccination, always in terms of prevention, will be the top choice.
And then I don't know if that is what you've heard or not, but I've heard some rumors that Canilesh is going to stop being produced because everyone is using Letifen instead. Because Canilesh, you need 2 to 3 vaccines, Letifen is only 1, and they're both quite expensive. So whether that's true or not, it's hard to know, but it doesn't sound unreasonable from a business perspective.
Yeah.
This is not, it's just an add-on from my experience. We do have a dog in practice that has been fully vaccinated from the age of 6, always straight on with spot-on treatments, with collar, and still has leishmania. And it is actually suspected to be a case of vertical transmission, as the mother was found to have leishmania after the litter was born. So we don't know whether this case was present before or not. But we now currently where we are, now where I am practicing, we recommend vaccination plus the collar and or the spot on still.
Of course.
So
and like you said it quite well when it comes to transmission. We focus, of course, we know the sandfly will be the bulk of the transmission, but we do have reports of vertical, even venereal transmission has been reported in anecdotal cases, and especially in humans, that's something to be discussed, and has been reported as well. So there's always that possibility. And if we're going to start finding patients that never traveled and all of a sudden they are positive for any other reason, we need to look at other forms of transmission, like the ticks and the fleas and other ways. So Leishmania has this. It's a beautiful thing to discuss in terms of how the disease progresses, but it's not fantastic because it limits us a lot. So hopefully in the future we'll get something a little bit better. But always vaccinate is always very good to prevent as much as possible.
Yeah. And now final question from me. How often do you see cases that are mild to moderate signs? You diagnose, you treat, you're like, okay, this is now not very clinical, we're just going to monitor this. How long does it take for you to see them clinically unwell going downhill again? And
it varies a lot. It does vary a lot. I've had patients where they were fairly okay, and then even shortly after the treatment, within a few months, they were just getting a bit worse. I've had patients where they were quite bad to start with. They responded very well to the treatment, and within 4 to 6 months, they were showing the strong clinical signs again, and the weight loss and the skin problems. And others that we've treated and we keep monitoring, and nothing else happens. So it's a high variability there, and it comes down to the individual. And as we discussed, depends on what kind of response the body is going to mount, and what is going to trigger for the Leishmania to replicate even further, and how they're going to show all these clinical signs. And I do not have a specific answer for that,
Yeah.
because it varies so much.
When you basically have them with worsening signs, you go back to the staging, and if they are like stage 3, you go back to treatment again with a leishmanicidal plus your allopurinol or whatever choice. So you kind of fluctuate between the different treatment options considering the stages that they're at.
Yes, you can definitely. And there was a paper from Brazil a couple of years ago, and they mentioned as a new protocol, of course, in an endemic area with a lot of Leishmania there, they were doing their protocol would be starting allopurinol, doing the leishmanicidal, and then repeating leishmanicidal within 4 to 6 months, as in a protocol, even though there was no clear change, to see if they could reduce the parasitic load. But it's not that common for us to do that within Europe, as far as I'm aware. But you can go back to say, should we go back to the leishmanicidal, because the options are there, but then we need to consider how much of a response you're going to get, and how much looking at the kidney disease and what stage we're at, and that will drive us from choosing one or the other. But of course, if we're getting a lot more clinical signs, allopurinol is not enough. Then we're going to add the miltefosine or the meglumine.
Yeah. Okay, cool. Final. I said it was a final question before. I'm sorry, I lied. I have one more. Have you ever had any cases of animals that fully recovered and became negative on antibody?
Yes, yes. Not a lot of them, but I did have actually. The last one was I think it was in the UK. Was a puppy that was imported from Spain. It was positive, and he was already being treated, and we monitored it. And within the first year, he became negative. And the first, for me to say we're not going to do anything else, and we're going to only monitor if we're going to have some signs. He had 2 negative consecutive tests, and that was 6 months apart, as we do the antibody titers, and both of them were negative. So that was great news for the owners.
Cool. So they do recover sometimes, occasionally, once in a while.
They can, yes, yes. We're looking for the clinical cure as it is.
Yeah. Do you have, I don't know why I have this idea that younger animals are better able of creating a response, a proper response. Like, this is your knowledge, opinion, experience?
So far, a bit anecdotal, but yes, I've seen younger animals mount a better response long term. Older animals to have a bit more of a struggle to maintain the clinical signs under control. Yes, but so it could definitely be related to the cellular response that they're going to mount, of how mature the immune system is, and how much of a load they've had to begin with. But yes.
Okay, that was the last question. I think everyone else has had their questions answered as well. So all I have to do now is to thank everyone that has joined us for your support, and for joining one more webinar, or the first one potentially. Hopefully we'll see you on another webinar. And to you, Ângelo, again, thank you so very much for joining us, for doing this presentation, for teaching me all about Leishmania again. It was really, really good. A lot of things I didn't know or remember anymore. So that's good to know. And I hope you had a nice time with us as well. And maybe you'll be back. And I hope you're not struggling too much with the heat where you are, because I feel like you're in a hot place. And it's probably still very hot at this time, and you see a lot of Leishmania there.
Yes, thank you very much for having me, and thank you everyone for your questions. It's always good. It's an absolute joy to do this. Thank you, Emily.
Thank you so much for joining us, everyone. And all I am left to do is wishing everyone a good day, good night, evening, wherever you guys are. And hopefully we'll see you all again.
Thank you. Bye,
Good
everyone.
night, everyone.
Bye.